wants to hear Dr. Jatin Shah. He is an icon in his own space, a man, a legend, has name carved in the present time, and in history he will go for a long way. Dr. Jatin Shah, we already know, is a celebrity IVF consultant, and he was my teacher in 1985 when I was a student in the prestigious St. G.S. Medical College. As a young lecturer, we used to get enthralled by his speech, by his lectures, and he has taught us the basic foundation of obstetrics and gynecology. We all know he's an MD, DGO gold medalist. He's the director of the Mumbai Fertility Clinic and IVF Center. He is a pioneer of setting IVF centers and has dedicated more than 35 years in this field. He has authored many textbooks and he has set up IVF centers in Kochi, Agra, Madurai, Erode, Chennai, Pune, and he has gone and given lectures in more than 500 national and international conferences, keynote addresses, and oration. He is also the founder member of the Asia Pacific Initiatives for Reproductive Endocrinology. Today we are going to hear Dr. Jatin Shah. Welcome, Dr. Jatin.
Thank you. Thank you so much, Niranjan.
Thank you. Thank you. Now I would like to introduce our esteemed panelist, and we have none other than Dr. Ragini Agarwal. Dr. Ragini Agarwal is an authority in herself in adolescent PCOS gynecology, and we want to hear from her experience. She is the Vice President of FOXY, a fellow clinical gynae endoscopy from UK, and has also taken fellowship in laser from Europe and American Academy of Aesthetic Medicine. We all know that she is the founder of the Gurgaon Obstetric Gynec Society, President-elect of Aesthetic and Regenerative Society, President of Indian Academy of Cosmetic Dermatology and Gynecology, and she has dedicated more than 30 years of her life in this field of obstetrics and gynecology. Welcome, madam. Welcome. Thank you so much. Then we have none other than our chairperson of the Maharashtra chapter of Indian Association of Gynecological Endoscopists, Dr. Prakash Patil. We all know he is the owner and is the director of Lifeline Hospital in Panvel, and he is also the member of the managing committee of ESHRE, AMC, IAG and IAGE before. He has got many awards and he has done more than 45,000 laparoscopic tubal ligations for the government of Maharashtra, awarded the prestigious award Kanushri Patanjali Puraskar 2007 award. He is going to also talk his experience of more than 35 to 40 years in PCOS. Welcome, sir.
Thank you.
Then we have the next speaker from UK, Dr. Anu Chawla. Who doesn't know her? She is a consultant and a specialist in reproductive medicine at Barts NHS Trust, London, a member of the Royal College of Obstetricians and Gynecologists. She's a visiting consultant to New Delhi. We see her in conferences of FOXY, ESHRE. Welcome, Dr. Anu. She's going to share with us her London experience. Thank you. Then we have Dr. Kushagrahi Ghosh. He's MBBS, MD, DNB, FICOG, FRCOG. We all know that he comes from east of India, a professor in his own right, an authority, and a department of obstetric and gynecology, Vivekananda Institute of Medical Sciences, Kolkata Health University. He is the past president of Bengal OG and Society, past chair of East Zone, AICC RCOG. Welcome, Dr. Kusha. And we have the Iron Lady from South India, Dr. Jayam Kanan, a very soft, humble lady, a very matured, more than 40 years of experience. She was the chair of FOXY Adolescent Health Committee in 2013-15. She was also the vice president of FOXY 2018. She has her own IVF center in Chennai, and she goes to Trichy also. She is got a lot of awards. She's got 13 medals, prizes in MBBS, and the state first in MBBS, university first in MD. She's got many books to her credit, Lifetime Achievements Award, and the Distinguished RCOG Award. Welcome, Dr. Jayam Kanan. So with this, we start our PCOS Demystified lecture, and we have Dr. Jatin Shah, who is going to talk on ART in PCOS. I welcome Dr. Jatin Shah. The mic and floor is yours. Please go ahead. Thank you so much.
Thank you, Niranjan. I'll just share my screen. Is everything okay, the audio video?
Yes, sir.
Yes. Yes.
So thank you, Niranjan. Thank
Yes,
you.
Jatin.
Yeah, okay. Respected and distinguished panelists, friends, it will be a pleasure to be invited here today. Of course, it's going to be a very difficult session because PCOS, as you know, is one of the most enigmatic and difficult clinical conditions that we deal with on a day-to-day basis. There's a lot to cover, and I'll try to do justice as much as possible to how exactly we go about treating a PCOS patient in clinical practice, especially from the infertility point of view. We all know that PCO occurs in almost 20 to 30% of all IVF patients, which is a huge number when you actually see any IVF clinic. And the reproductive manifestations of PCO are well known in the form of oligomenorrhea, secondary amenorrhea, because of anovulation, which in turn leads to infertility. And if at all they conceive, they do have a higher incidence of early pregnancy loss and also a higher incidence of gestational diabetes because of obesity, higher incidence of cesareans, and so on. I'm sure all of you are familiar with that, but just some new insights into the etiology, that it's probably not a single gene defect and more likely to be of a polygenic or oligogenic origin. We also know that low birth weight and fetal exposure to androgens may contribute to the development of PCO later in life. Low birth weight is particularly associated with insulin resistance and obesity in adulthood. And we also know that AMH levels are increased in daughters of women with PCOS during infancy, early childhood, and in pre-puberty. So there are a lot of interesting developments on the genetic side, and it's linked to PCO. What exactly causes the chronic anovulation? Of course, it's the relative deficiency of FSH, because of which you don't have follicular recruitment, and there is a lot of aberrant hormonal environment or a milieu in a PCO patient. And this results in abnormalities in ovarian steroid production, both the theca cells, which secrete excessive androgens, granulosa cells with increased aromatase activity resulting in hyperestrogenism. But just to put things into scientific perspective, if you look at the various hormones individually, LH would be increased in almost 60% of PCOs. The LH-FSH ratio would be altered in almost 95%. Androgens are increased in 50 to 70%. Prolactin is increased in 30%. SHBG is decreased in about 50%, and insulin is increased in almost 50% of PCOS patients. From the IVF perspective particularly, we know that obesity or insulin resistance will result in abnormalities of mitochondrial morphology. So it's very important to remember that when we do a PCOS stimulation, you feel you got a lot of eggs, you get 15, 20, 30 follicles. But remember that all the oocytes may not be the best. We also know that obesity and high-fat diet will cause reduced mitochondrial membrane potential, both at the germinal vesicle, the GV stage, as well as the metaphase 2 stages. And this in turn will cause poor oocyte and embryo quality in these women. Also, when you are doing an ovulation induction, does it mean that if she ovulates, she gets pregnant? No, it is not like that in PCOS. We know that at every stage, you will have a problem. So she may ovulate, but the oocyte quality may not be the best, as I showed you earlier. She may fertilize a good egg, but the endometrium may not be receptive because of the hyperestrogenic atmosphere. You may have endometrial hyperplasia. You may get implantation, but you may also have early miscarriages because of hyperinsulinemia. And even if she goes through pregnancy, there is always a higher chance of gestational diabetes, PIH, and LSCS. So it's a long journey from your ovulation induction to actually getting the live birth. We more or less have a consensus now, so we are easy on these lines, but we need to fine tune each step. The first line of treatment, of course, always is the use of aromatase inhibitors or clomiphene citrate. If that fails or if there is CC resistance, the second line is usually laparoscopic ovarian drilling, which I'm not particularly a fan of, or the use of gonadotropins. And the third line is, of course, IVF, which today, thanks to vitrification, thanks to the agonist trigger, thanks to freezol, is the most successful treatment for CC-resistant PCOS. So let's briefly, I'm sure a lot of the audience does a lot of ovulation induction with timed intercourse. But if say 2 or 3 cycles of that fails, you would obviously want to move on to IUI to improve your pregnancy rates. Remember, PCOS is not a very easy category as far as IUI goes, because you want to restrict your number of eggs to just 2 or 3. Now, this is the tricky part where it is not very easy to make sure that you don't get 7, 8 or 10 follicles. Most PCOs, they always have a tendency to hyperstimulate. So clomiphene, what I find usually 100 milligrams works best. You could start with 50 and then do 2 cycles and go on to 100. But generally, if you start with 100, you are likely to get a good response, especially in the high BMI obese categories. And what you need to remember here is that more than 150 doesn't improve the ovulation rate. But most importantly, 75% of pregnancies achieved with clomiphene are usually within the first 3 cycles. So please remember, in a PCOS, you can start on day 2, 3, 4, 5, 6. It's all the same because she's anovulatory. No dominant follicle is going to come until you don't start CC. And as I told you earlier, less than 50% patients respond to 50. So 100 seems to be a more ideal starting dose. Monitoring, I'm sure all of you are familiar. You wait for 2 or 3 follicles to reach 18 to 20 millimeters in mean diameter. Endometrium preferably above 7 millimeters, ideally 8 to 10. And you would plan your IUI at 36 to 40 hours post HCG. Again, to drive home the point that just don't keep persisting with the same modality, you can see almost 50% of pregnancies that you get with CC will be in the first cycle, about 15 to 20% in the second cycle, and very low success rates after the third cycle. Should you cancel? Should you panic if the endometrium is not too good in a clomiphene cycle? Not really. If you look at this slide here, of course, pregnancy rates peak at around 10 millimeter thickness of the endometrium, but it is not 0 at less than 7 millimeters. So you have to remember that if she has a good follicle, your endometrium is around 7, you can still go ahead and hopefully may not get a 20% pregnancy rate, but 10 to 12% is not bad either. Another classic paper here from 2017, which clearly showed there was no real evidence for any association between endometrial thickness and pregnancy rates in OI, IUI for PCOS cycles. So cancelling a cycle because of a thin lining is not indicated. And also pumping in exogenous estrogen during a clomiphene cycle doesn't really help in improving the endometrium. Of course, we had a big breakthrough for PCO in 2013 with Legro's first paper showing letrozole had a clearly 44% increase in pregnancy rate as compared to clomiphene citrate. And today we know that it is probably considered as a first-line treatment for PCOS before you use clomiphene citrate. Even when you're using a sequential protocol, which is very common in India because we like to reduce the costs, when you compare clomiphene HMG with letrozole HMG, again, letrozole HMG scores much better in terms of clinical pregnancy rate as compared to clomiphene. In 2017, again, we had this paper which corroborated the same findings that should letrozole, would it generate better pregnancy rates than clomiphene? And clearly, they found a much higher clinical pregnancy rate of 61% as compared to 43% with clomiphene citrate. So we clearly know now that aromatase inhibitors, especially letrozole, should be first-line treatment for these patients. A unique paper I came across, I have not yet really tried this, but this is comparing letrozole alone as against giving a combination of both 2.5 milligram letrozole and 50 milligram clomiphene together from cycles day 3 to 7. They did 70 patients and they found that the combination group had a statistically higher ovulation rate as compared to letrozole alone. Of course, the side effect profile in both considering multiple pregnancies and all was the same. And they concluded that, of course, we need further studies because this is just one paper talking about this, but it's an interesting concept which needs to be followed up. Finally, of course, if letrozole fails, clomiphene fails, you don't have any other option but to go for the gonadotropin cycles. Step down, classically, what we do for non-PCOS patients would not be the ideal way for PCO, because if you start with 150, you're not going to get 2 or 3 follicles, you're going to get an explosion and 10 to 15 follicles, which you don't want at any cost. So the best way to approach PCOS is to do the chronic low-dose step-up protocol. Now here, of course, some papers say start with 25 to 50, some say 37.5. Maybe you could start with 50 to 75 IU depending on the BMI of the patient if you want to avoid a very long follicular stage. And then gradually every 7 to 14 days, you step up the doses in small increments till you get a dominant follicle. Once you see a dominant follicle, don't step up the dose. Just continue the same dose until you have a follicle reaching 18-19 millimeters, which is when you administer the HCG and plan your IUI. what I find really works well and what I've been practicing for the last almost 5 to 6 years now is to have a starting dose of 75 to 112.5, depending on the BMI of the patient from day 3. And instead of waiting 7 to 14 days, you can increase the increments, or you can make increments every 2 or 3 days so that you have a shorter follicular phase. And some of you might feel that with this, you will again get hyperstimulation. But fortunately, the incidence of monofollicular cycles, as this paper shows, is as high as 40%. Pregnancy rates are on par with non-PCOS patients. And surprisingly, mild OHSS, just mild OHSS is only 10%. No moderate or severe OHSS were seen in this study. So if you fine tune, you could reduce your cost by starting with 112.5. You don't have to worry about a 20-day, 30-day follicular phase with so much of gonadotropin being pumped in, as in the earlier recommendations of the chronic low dose step up. For those of you who are starting and worried about hyperstimulation, a good nomogram to use, you plot the antral follicle count versus the weight of the patient. For example, you have a patient 65 kilos with an antral follicle count of 15. And if you plot it, you get a starting dose of 75 IU. So this is how you could use this initially. And it's very easy to do so that you don't go wrong and you don't end up with hyperstimulation in your OI patients. Now, whatever you do, 1 in 4 patients will get a premature LH surge. Now, that is the problem. The minute you use gonadotropins, 25% of patients will have the premature LH surge. So you're losing 1 in 4 patients having a chance of pregnancy because of this LH surge. So personally, I would recommend that if you are using gonadotropins and if you know that the patient in a previous cycle has had LUF, or she's not ruptured the follicles, or she didn't conceive, or any of those things which suggested a premature LH surge, it's best to use an antagonist with the gonadotropin, which you just start from the day the follicle reaches 14 millimeters in mean diameter and continue it until the day of HCG, and you should be reasonably through with a very good pregnancy rate of as high as 22%, as his international paper shows. Our own experience was at around 33%. Of course, most Indian statistics are always better because our women on an average are 10 years younger than the Western women. So it's not that we do anything better, we just get the advantage of younger patients. So addition of an antagonist definitely helps in cases of PCO, especially because estrogen levels may be higher than non-PCOS patients, making them more prone to the premature LH surge. IUI, best results if you do it at 42 hours post HCG, which as the study shows, you get the highest pregnancy rate as compared to doing it immediately after HCG or at 36 hours or at 48 hours. So the best time seems to be just about 2 hours post ovulation, which is usually around 42 hours. Clomiphene cycles don't need luteal phase support, but anything else, when you use gonadotropins or when you have used combination or sequential protocols, it is mandatory to supplement the luteal phase. Vaginal progesterone suffices for most of these patients. You can see here vaginal progesterone, vaginal gel, vaginal capsules all give you similar pregnancy rates. No luteal support definitely does not give you good pregnancy rates. So it is mandatory in these cycles. We now have the results of the Lotus trial, which say that you could totally bypass MVP. Of course, we all are so used to MVP for the last 25 years that it's still not very easy to make a total shift. But apparently, if a patient is not too comfortable inserting something vaginally, you could give her the option of using oral dydrogesterone, and they say just 30 milligrams a day is sufficient if the patient has a corpus luteum. So any cycle where there is a functioning corpus luteum, which will always be there in your OI, IUI cycles, you could use dydrogesterone as an option. Now, the biggest problem that all of you will face when you use gonadotropins in PCOS will be hyperstimulation. So please, if you have the guts to do gonadotropins for IUI, you must also make sure that you have a good tie-up with a neighboring IVF clinic. At least 30 to 40% of your PCO patients will produce an excessive response. So whatever you do, you use the nomograms, you do 75, you do 100, and if you see 10 to 12 follicles, you are asking for trouble. Anything more than 15 to 20 follicles, serious trouble in the terms of OHSS as well as multiple pregnancies. So you must counsel the patient before you start that I am starting you on gonadotropins, but if there is an excessive response and you don't want to cancel the cycle, we have the option of converting it to an IVF, where they will give you the agonist trigger. They will pick up all the eggs. They'll freeze all the embryos. You will not get any OHSS with this kind of treatment. And your success rate goes up from 20% to almost 60%. So it's fantastic if you counsel the patients beforehand. It really works like magic. And we know that since you are already doing a gonadotropin cycle for her, there's no point going back to clomiphene and letrozole, cancelling the cycle. It just makes a mess and you're probably going to lose that patient. So patient will always remember you better if you've counseled them about these risks, about hyperstimulation, and there may be a small chance, 30%, that I might have to convert you to an IVF, not compromising your treatment, but giving you a higher success rate. Of course, please be wary now. Why I keep saying we want just 2 or 3 follicles. If you look at this data, 22% of all twins, 40% of all triplets, and 70% of all quadruplets in that particular year in the US were not from IVF cases, but they were from OI and IUI cases, especially a lot of PCO patients. So multiple pregnancy is a real and serious danger in PCOS. The minute you use gonadotropins and she ruptures 6, 7, 8 follicles, and that is where you get all your triplets and quadruplets with all the associated morbidities involved. So please be very careful of that. Now, since we are talking of PCOS, I just need to touch upon a bit of LOD, although it's not my favorite procedure. I try to avoid it as much as possible, but they say that, okay, if a patient is from a remote area, she doesn't have access to ultrasound, to gonadotropins, can't afford all that, she is CC resistant, and she just needs something to help her conceive, maybe you could do as per the standard new procedure, which I'm sure all the endoscopic surgeons on the panel would know better, just making 3 or 4 drills without using too much of cautery or whatever the latest technique is, and hope that maybe 50%, as this paper showed, would get pregnant in the next 6 months. Of course, we have to be a little careful with this. And here we have a large study from last year, 2019, that given a patient in a city with access to ovulation induction, gonadotropins, IUI, and IVF, if you compare the use of letrozole with LOD, there was no difference in ovulation, pregnancy, live birth rate, or abortions between the 2 groups. So this clearly indicates that both are equally effective as far as achieving live birth is concerned in patients with CC-resistant PCOS. What I really get scared of, and I've seen too many cases of this happening, which is why I'm really, really scared of doing the LOD procedure, and that is the effect on the ovarian reserve. We know that there is a growing concern of possible damaging effect. All these meta-analyses have clearly showed a statistically significant decline in AMH after LOD. However, they also add that it remains uncertain whether this reflects a real damage or just normalization of the high preoperative serum AMH levels. So we need further long-term studies, but I have seen a lot of them not recovering. AMH is of 8, 10, 12 before surgery, and after surgery report comes 1, 1.2, 1.5. I'm sure all of you would agree with that. So please be very careful with this procedure. Of course, if you're doing a laparoscopy for some other reason, in a case of PCOD, it would be best to do a minimal drilling and improve her chances of spontaneous conception a bit. Some good guidelines for you, especially the ASRM guidelines for ovulation induction in PCOS, still happens to be in press, but I got access to it, and you can see letrozole should be considered first-line treatment. CC with metformin for women who are CC resistant. The risk of multiple pregnancies increased with clomiphene, so monitoring is critical. You can't just give them clomiphene and leave them alone. Gonadotropins as second line if AI or CC have failed. Gonadotropins could be used as first line. Now, this is very important if you are an experienced infertility specialist with a good hand on gonadotropin and ultrasound monitoring, then you could use this as a first line too to cut short the time to pregnancy. Of course, after counseling the patient well enough on the cost and the potentially slightly higher risk of a multiple pregnancy. LOD can be used if laparoscopy is required for some other reason, as I told you earlier, but always consider the probability of periadnexal adhesions and probable loss of ovarian reserve. And when any gynecologist uses gonadotropins, please be aware about cost and availability. Please counsel the patient about these factors. Expertise, intensive ultrasound monitoring, prefer low dose protocols so as to optimize monofollicular development, and always counsel about multiple pregnancies. Now, again, friends, IVF is not a first-line treatment, but why I have to mention IVF is because finally all these patients who fail OI, fail IUIs, fail clomiphene, fail letrozoles, fail gonadotropin IUIs will end up in an IVF center. So IVF will be indicated, of course, primarily if there are other factors such as a tubal or a male or endometriosis, failure to conceive despite 6 OI cycles, failure to conceive with other measures for clomiphene resistance, Excessive response to FSH, which I told you is a beautiful approach where you just convert from an IUI to an IVF cycle. You can expect fantastic pregnancy rates. And of course, to eliminate the risk of multiple pregnancy, because in IVF, we can control and do an elective single embryo frozen transfer. So it's very easy to control things in IVF. When we talk of stimulation, of course, we want to eliminate hyperstimulation in a PCOS. That's the only worry. And until recently, it was believed that for best success rates in a fresh embryo transfer, the ideal number of oocytes was say 5 to 15 with an average of 13. But with these times of vitrification with excellent frozen embryo transfer results, previously in PCOS, we could not titrate to 13. We would always end up with 20, 25 eggs, then some hyperstimulation, then pregnancy-induced hyperstimulation, and low pregnancy rates, as you can see here, because the endometrium is not receptive with the supraphysiologically high levels of estradiol and progesterone. But we now know that cumulative live birth rates are excellent. If you count fresh or you count just the frozen pregnancy rates, you have an increase in cumulative pregnancy rate right up to 27 oocytes. So we are no longer worried in a PCOS about the number of oocytes. Even if she gives 100 oocytes, there's not going to be any hyperstimulation with the use of the agonist trigger and a freeze-all policy. So of course, who is the high responder? We know all PCOS, especially, of course, there are different studies saying 5 is the cutoff, 3.36 is the cutoff. But I feel any patient who has an antral follicle count of say more than 15 or 20, especially the young, thin, lean PCOS, any patient who has a history of hyperstimulation, and I would put a cutoff with Indian laboratories at say about 3 to 3.5 max, above which we should expect that the patient will behave as a PCOS patient. Until now, the biggest problem was hyperstimulation. We found had a lot of difficulty in reducing or increasing gonadotropin doses during the cycle. So there was a higher risk of cancellation, there was a high incidence of hyperstimulation, and a higher risk of spontaneous early pregnancy losses. Also, we know that when you have more than 15 oocytes, you have an increase in the incidence of hyperstimulation, especially beyond 16 oocytes. So these were the problems we had. But now the take-home point of the whole lecture is that it's all things of the past. So now we don't have hyperstimulation. All good IVF clinics are OHSS free. If you have predicted the high responder right in the beginning, you use the antagonist protocol, you give an agonist trigger, you freeze all the embryos. So the 3 musketeer approach is the best for all these patients. And of course, antagonist protocol, we know that you start from day 2, the FSH or HMG, add antagonist at 14 millimeters, continue both. Then of course your HCG trigger and retrieval at 36 hours. Now the agonist trigger is what revolutionized the treatment of PCO. We know now that if you give 0.2 milligrams of triptorelin, you will get the same cohort of metaphase 2 eggs that you would have got with an HCG trigger. But the corpora lutea will be highly deficient because LH, which is released because of the agonist trigger, has a very short half-life compared to HCG, which has a longer half-life of 7 days. So the corpora lutea resolve within 24 hours. You don't have a good luteal phase, so you cannot do a fresh embryo transfer. Even high-dose estradiol progesterone, like a lot of authors said, okay, let's pump in 12 milligrams of estradiol, let's give them 200 milligrams of progesterone, but nothing really worked and the pregnancy rates were dismally low. Also, add back HCG. A lot of authors said that, okay, you give agonist trigger, pick up the oocytes, then give 1500 IU HCG on the day of pickup to rescue the luteal phase, then do a transfer. Yes, it works for pregnancy rates. You can come back to around 50%, but again, an unacceptably high incidence of hyperstimulation, and this is usually the pregnancy-induced hypertension, pregnancy-induced ovarian hyperstimulation, which is the more dangerous variety and which goes on for 20 to 30 days. A lot of you have, some of you might on day 7 feel that, oh, she's got too many follicles, let me reduce the dose. These kind of knee-jerk reactions don't work in a PCOS patient or in any patient for that matter. Suppose you are giving her 225 and you drop down to 100 because there is too many follicles seen around day 7. Psychologically, you feel, oh yes, now she will not recruit any new follicles. But is that the truth? We know that it takes 3 days after you drop the dose for the FSH concentration to fall below the threshold and end any new recruitments. So whatever you do as a knee-jerk reaction, dropping down doses, reducing doses, doesn't work in IVF. All you will do is might reduce the estradiol levels a bit, but in that bargain, you will compromise on oocyte quality, embryo quality, and your final success rate. So when I keep saying freeze all, what does it mean? It means all viable embryos, not the second best embryos, are frozen and then transferred in a subsequent cycle. So this is how we went on for PCOS, our first study in 2015, 127 patients, all on the short antagonist cycle with a fixed dose of REC-FSH 150, 0.2 milligram triptorelin trigger to all, no HCG trigger was used. Vitrification for all was done on day 2. Third transfer was done in an agonist and estrogen progesterone prime cycle in the immediate subsequent month. And the pregnancy rates in the first frozen transfer was straight away around 60%. And even if you discount the early pregnancy losses and ectopic pregnancy, a good live birth take-home baby rate of close to 15%. What other treatment do we have that is so successful for PCOS, which is resistant to CC or aromatase inhibitors? So this has really revolutionized the entire treatment of PCOS. You can see month after month, consistently the results are around to 50 to 60%. Even 2019, it continues to cross 50%. So freeze all is the way to go. The other problem in PCOS is that the more the number of eggs you get, the higher is the incidence of premature elevation of progesterone on the day of HCG. So you can see most of your PCOs who will give you more than 18-20 oocytes will have almost a 20% chance that their progesterone will be high, which will result in an advancement of the endometrium and therefore very low pregnancy rates. The minute you do freeze all, you can see the blue are the freeze all, the red are the fresh transfer pregnancy rates in patients with premature rise in progesterone. Clearly the freeze all scores much better, especially in PCOS. A slide which I love to show again and again because this is the commonest problem which we see. What do you use for programming or scheduling? Please avoid OC pills when you are using programming for a PCOS patient. We know that the longer the duration, especially when you give more than 14 days and you go on to 20, 25, 30 days, there is too much of a suppression of endogenous FSH LH. And these are the patients who will be high responders. They will need an agonist trigger. If your endogenous LH is very low, the agonist trigger will not work as it should be working. And you can see here, the higher the suppression of LH at the start of stimulation, which will be the more the OC pill that you have given, the higher will be the suppression. Almost 35 to 50% of cycles will give you a suboptimal response. So please be very clear and don't use OC pills for these patients. What works better? Just give the antagonist. Just give an antagonist on day 2, 3, 4, and that's all you need to do. You can push the cycle by about 3 to 4 days if you want to avoid a weekend. You don't need to put her on OC pills for a very long period of time. Also, some of these PCOS patients will have elevated progesterones even at the start of the cycle. And you can see here, even here, you just give antagonist on day 2, 3, 4, then begin FSH from day 5, then again the antagonist when you have a follicle of 14 mm, and then go ahead. And you can see here, after you give 3 days of antagonist, progesterone levels will normalize immediately. Just 3 days is enough. And you get back pregnancy rates on par with your normal progesterone group. So these are simpler ways of programming. Is FET safe? What are the advantages of doing a freeze-all in a PCOS patient? You have a reduced risk of low birth weight, small for gestational age, definitely reduced incidence of biochemical pregnancies, ectopic pregnancies, and early miscarriages and early pregnancy losses, which are particularly high in PCO patients. So all these are the benefits that you get with freeze-all. The only disadvantages which have been claimed are, there are only 2 studies which say that the babies may be macrosomic, but the difference in weight is just about 200 grams. And there are a few case reports of placenta accreta because of a stronger implantation with FET. Any impact on the babies? This huge study from 2016, clearly no difference in malformation rates of any malformation, whether you do fresh or frozen embryo transfer. Something which should be a main point today for today's lecture. Till now, we always thought that FSH is the way to go. That means if you have PCO, they have high LH, you should not give them LH, you should not give HMG, you should only give them pure FSH. Then we went to highly purified FSH, then we went to REC-FSH. Do we have anything new for them? Just a few days ago, we have the Megaset trial published now, which compares HMG versus REC-FSH in PCOS patients. So we have 150 IU of HP-HMG or REC-FSH given in these patients. Then of course the monitoring and the addition of antagonists is as usual, HCG is as usual, luteal phase support and transfer of a single embryo blastocyst. And if you look here, What is really interesting is that the ongoing pregnancy rate in fresh cycles significantly higher with the HP-HMG as compared to REC-FSH. This is with fresh transfer. Even if you look at frozen embryo transfer, pregnancy rates are much better with HP-HMG as compared to REC-FSH. Early pregnancy losses are lower with HMG as against REC-FSH. Now, this is a real revolutionary, means the whole thing, the wheel has gone around. We were taught initially, of course, we used only HMG because we didn't have FSH. Then we moved along for 20 years to pure FSH for PCO, that let's not use anything. They should not be given LH. It affects the egg quality. Now we have evidence from this huge trial that everything has gone back to saying that even PCO patients, LH might be beneficial from the beginning of stimulation. And again, if you look at OHSS2, drastically reduced incidence of OHSS with HP-HMG as compared to REC-FSH. So a lot of benefits here, higher pregnancy rates. Of course, it's all finally your personal experience. We'll need many more centers to corroborate the same findings, but it's a huge study which clearly proves that HP-HMG is the way to go. Of course, before we end, just a few other adjuvants. We know that obesity will affect PCO results. So higher the BMI, higher is the gonadotropin dose required. Lower is the rate of oocyte recovery, sometimes lower pregnancy and live birth rates. Of course, this is a bit controversial. There are some papers which show that they do equally well as the normal BMI patients. And sometimes you have practical difficulties with accessing the ovaries, anesthesia risk because of obesity and difficult embryo transfer. Which patients need insulin sensitizers? Now, this is again very important. Every PCO patient who goes for IVF does not need metformin, myoinositol, or any of these things. You have to be selective. So patients with proven glucose intolerance and insulin resistance, obese patients with a high BMI, CC resistant women, reduction of hyperstimulation during IVF stimulation. This is if you are using the conventional agonist protocol. I'm sure none of you do that now. Everybody knows that for PCO you use only antagonist protocol because you will need an agonist trigger. Alone, just by themselves, metformin is not as effective as clomiphene or letrozole for ovulation induction. And there was some papers and publications that it might help to reduce early pregnancy losses if a patient of PCO has had recurrent pregnancy losses. So a lot of older papers, 2007, in favor of giving metformin co-treatment. But what is the recent consensus? In 2014, we have one of the largest meta-analysis done that metformin before, during, or after egg retrieval does not improve live birth rates. A lower incidence of hyperstimulation in agonist cycles, but not with the more popular antagonist cycles which are used nowadays. In 2016, again, in fact, they showed a reduced live birth rate with metformin versus placebo and no difference in hyperstimulation or number of oocytes. 2018, again, no significant difference in live birth rate in agonist protocols with addition of metformin. In fact, they had fewer oocytes retrieved in the metformin group, just 9 versus 16 in the non-metformin group. So we really don't have any justification now, except for the 5 or 6 categories which I showed you, where metformin should be given as an adjunct. And finally, how do patients finally do with IVF? I showed you they do very well with the freeze-all, excellent pregnancy rates. Even this paper from as way back in 2004 with fresh transfers showed all the results on par with tubal factor infertility, except of course there was a very high incidence of hyperstimulation in those days because you didn't have the antagonist and agonist trigger. That has all changed now. Obstetric risks, yes, there is a 10 to 15% higher risk of early pregnancy loss. There is a 3 times higher risk of gestational diabetes, 3 to 4 times higher risk of pregnancy-induced hypertension, odds ratio of 1.75 of preterm delivery, increased perinatal mortality, odds ratio again 3 times higher risk, small for gestational age 10 to 15%, higher incidence of LSCS2. What about the risk to the female offspring? Again, we know that when a PCOS patient delivers a female offspring, there is a higher risk of developing PCOS in the daughter. The daughters have been found to have increased LH and testosterone, hyperinsulinemia, and increased ovarian sizes during puberty. So to end, of course, we need to look at the ESHRE guidelines for high responders. OC pills 12 to 28 days is not recommended because lower live birth rates and ongoing pregnancy rates. Antagonist protocol, of course, is here to stay. No question of using an agonist protocol with regards to safety, which is of prime importance in PCOS patients. Adding clomiphene or letrozole to FSH in an IVF cycle in a short protocol is not recommended. There were some papers that you add letrozole, OHSS goes down, gonadotropin ampules go down, and so forth. Rec FSH and HMG equally recommended, and if the megaset trial is further corroborated in most centers, maybe HMG will again come back as the molecule of first choice. Adjustment and sudden knee-jerk reaction adjustments of doses on day 7, day 10 don't work, because physiologically it takes 3 to 5 days for the new threshold to be achieved, and therefore you're not going to stop new recruitment for the next 3 days. Routine use of adjuvant metformin before and or during stimulation is not recommended in the antagonist protocol. In the agonist protocol, if you still happen to be doing batch IVF and you are daring enough to be able to treat OHSS and you are using the agonist protocol, maybe metformin will help you reduce the risk of OHSS. Addition of estradiol measurements is now obsolete. You don't need to do it. You have to give an agonist trigger, whether a estradiol is 3,000, 5,000, 10,000 or 20,000. Agonist trigger is recommended, of course, as I told you earlier. Freeze-all strategy is recommended. Cabergoline or albumin as additional preventive measures are not recommended. When you use an agonist trigger, please sleep peacefully. Don't give that one albumin and don't put her on cabergoline. She doesn't need anything. At the most, you just warn her about torsion. Very rarely rupture of a cyst or hemorrhage, maybe 1 in 1,000. And just warn them that, okay, avoid any jerky movements for the next 5 to 6 days so that we don't have torsion. So with that, of course, once again, I'd like to thank Niranjan. I want to thank all my esteemed panelists for agreeing to be a part of this excellent program. I have to, of course, thank IAG for inviting me here today. And of course, Science Integra, Sun Pharma, all their divisions for being such excellent academic partners. Thank you very much.
Thank you, Dr. Jatin. It was a wonderful presentation. You took us on PCOS and use of controlled ovarian stimulation, use of GnRH agonist, antagonist, metformin, and the different trials like Lotus and all the trials which you have said, and your, of course, experience of 35 years. It was a wonderful presentation. We will come back to you. There is a request from the organizers that continuously people are trying to enter this panelist link. So I would like to announce here on the open forum that by mistake, one of the panelists has shared this Zoom link by mistake. I request him or her to please tell their user friends or on groups to please forward the digital TOG webinar link. It has already been displayed here and it has been already sent to you, but by mistake, it is coming here. So I would request them to please join in that link. This link is only for the panelists. Okay. So thank you, Dr. Jatin sir. We will come back to you soon. Now I request Dr. Ragini Agarwal, who has joined with us, to briefly tell us about adolescent PCOS and what is her experience in that. Your time starts now. Thank you so much.
Okay, thank you, Niranjan. When we talk about the adolescent PCO, there are a few wonderful slides which are shown by Dr. Jatin Shah that we always remember why this, I can say now the word pandemic is, PCO is there. More girls from the PCO mother, our esteemed friends by IVF, they are making them pregnant and they are coming. And the second thing, with genetic disposition, with the environmental effect which they are having, it has become a lot PCO, which come across in our day-to-day routine practice. Now, why this adolescent PCO is very different? We cannot label on a ultrasound which they are coming and we say that this girl is a PCO and label her as a PCO. We have to be little bit not label a PCO girl before going in a deep, not putting the Rotterdam criteria on them, but thinking that an evolution number 1 is common in the adolescent. Their ovary is little bit larger. They can have a mild hirsutism. Acne is again a part of a growing age. So until unless it is a persistent and an evolution is persistent, we should keep a watch on them. And the second, the most important thing on the adolescent is that when an infertile woman comes to you, she is ready for each and everything. But when the adolescent PCOS come, already we know that the teenagers are very, very volatile and they go in the depression. They are they are not so developed to understand and analyze each situation. So what they need a proper education, understanding of the problem. We have to sit down with them with a non-judgmental way, how we handle to adolescent for anything, and alone, because they are an entity, they are not an appendage of their parents. We have to give them the education. And the second thing which is very important with the adolescent, we cannot say that, look, you are obese, you have to reduce your weight. This go in a very, very wrong way. It makes them more depressive. So very sensitivity is very important with the treating with the adolescent. Number two, how to educate them. And the third most important thing, we have to catch them young to prevent the future sequelae, especially the infertility. And this is the time when we make them understand for the lifestyle modification. So nutrition, exercise is the most important thing. And the third most important thing in these patients, in this adolescent, is a cosmetic concern, which we can't overlook. If I say that first we will manage your PCO, balance your hormones, then we can take care of your acne and hirsutism. This is not right. They are not going to stay. Most of the adolescent which comes to me, they are coming for the hirsutism. They are coming to the acne, to my better half or my son or my daughter-in-law. And then from there, they come to me for the obesity and detailed PCO education. So their prime concern is always not the menstrual irregularities, that we have to think, and our gynec colleague should transfer to those girls to a dermatologist, not give a topical treatment to them, because the hirsutism, because this acne is not going to respond very well to the topical treatment also. And the last but not least, don't jump to the COCs always for these developing girls. Before going for the COCs, think what she really requires. It is a metabolic disorder also. So don't forget to go for its metabolic component, control that metabolic component, control with the insulin sensitizer, and many a time you don't require so much of the COCs, and educate them. Every month menses is not a necessary. If they bleed 4 to 5 months in a year, that is also very good. So my take-home message to all for the adolescent PCO, number one, treat them as an entity for themselves, not as an appendage of the parents. Number two, always take them in confidence and take their cosmetic concern as a prime importance. Give them a lifestyle modification, and initially all with these things, with the progesterone bleeding is more than enough, and COC comes in the last in the managing these things. Although COC is with the spironolactone, we all know there's a thromboembolic phenomena is attached this. Even in my personal experience, one of my friend's daughter, she is 19-year-old and she has a thromboembolic phenomena. I have given her Crimson 35. I was the person. I cannot forget that situation for that girl. So these smaller points is very, very important, which we should take.
Thank you, madam. Thank you so much. It was a wonderful experience of you sharing. I hope you also get young girls as 13 and 14 and 15 years. You got a 19-year-old girl, you gave an example. So do you get younger than those girls who are just 13 or 14 with PCOS? Or they are usually up to 18 or 19, madam?
No, I get patients starting from say 10 years, because many of my deliveries who are coming to me, and 10 years onward, mostly patients who came with the younger girl, usually they come with the excessive bleeding, not the amenorrhea. Many girls who comes to us with a menorrhagia, and finally with the all investigation, we came to the conclusion it is an initial stage of a PCO only. So this is not always the adolescent girl coming with a problem, and we think of the amenorrhea or oligomenorrhea also. Even HMG we have to think. Then the second group which are coming with a obese patient, very, very obese patient. This younger adolescent population is a very different what we see with the patient coming us for the reproductive problem in the say in that age group.
Okay.
So with the 13, 14 years, I never put on the COC until it's really, really required.
Okay. Thank you. We will come back to you. Dr. Jayam, you wanted to add some few words.
Yes. I have been the chairperson. I have been working in adolescent. Everybody knows that I am the adolescent person for all India level. So as Dr. Ragini
Madam,
has
you are
put it
also
very-
adolescent, madam.
Thank you, Niranjan. For you, I am always an adolescent. See, the diagnosis of PCOS in adolescent, the last year Barcelona criteria, which has run into about 106 pages, has made it very clear that all the Rotterdam should be clearly filled up. You can't have 2 out of 3 and all the 3 must be there. When we take all the 3 together, the ultrasonographic morphological diagnosis of an PCOS in adolescent gets drastically reduced down to 50% of the existing strategy. That is one small thing. The second one, what she talked very clearly is the excessive bleeding which is seen in adolescent. That is one thing which has to be taken up very much into account, because many of us clinicians think that when they have excessive bleeding, she may not be a polycystic ovary. But to make a diagnosis of a polycystic ovary as early as 10 years should be done with a lot of caution, because in those sort of people who are below 15 years, all the 5 criteria, including the insulin sensitivity, has to be taken into account. Otherwise, we have a very difficult future for them in their time to come. That is what I wanted to add a little more.
Thank you, madam. Now we go to Dr. Prakash Patil. Will you please unmute your mic so that we can hear you? Dr. Prakash Patil, your time starts now. Please unmute your mic. There is this button which tells to mute and unmute. So you can do that from your side. And we want to share your experience of IVF and PCOS cases. Dr. Prakash Patil, kindly unmute your mic. Thank you.
Yes, Niranjan. Good evening to everybody, all the panelists. And thanks for giving this opportunity, Dr. Niranjan, and all our sponsors. Dear friends, I'll be just sharing some practical experiences. One thing I just wanted to tell you that our panelist, Dr. Jatin, he has covered almost the whole PCS in ART. He has taken out the chunk in the obstetric career. Then Dr. Ragini has covered the remaining, that is adolescent. What is left out is the natural conception in PCOS, that is one. And second, PCOS care in perimenopausal, which will not be interested to listen. So whatever is possible will, it may be repetitive, but we'll try to cover in 7 minutes what you are given me. Dear friends, everybody knows PCOS is a most common endocrine dysfunction in women. Almost 14 to 45 females are suffering from PCOS. Management of adolescent, the way Dr. Ragini, our Foxy Vice President, said, that is right. COCs are not very routinely used. We are not using, earlier we used to use. But the most important thing is counseling of the patient and the relatives is we take almost more than half an hour for that counseling. We tell them to go on Google and everywhere and then study your pathophysiology. We explain them everything so that they are convinced that this is not a disease, this is just a condition. Then regarding the reproductive age group, patients with rigorous cycles who don't disease, but they want to conceive. In these patients, after 5 days, every time we are giving them that their cycles are they conceive and they continue. Clomiphene cited, I think Jatin has already spoken in details that in some patients clomiphene should be given doses. So we'll not talk about clomiphene. Most important is metformin, which now very frequently and everybody is using it as a first line of treatment It's a potent ovulation induction agent, first drug of choice in anovulation in PCOS, and it has got short half-life, no anti-estrogenic activity, monofollicular development, and good pregnancy rate. Doses are used by different people different way. Some people they give 5 milligram OD on third to day. Some people are giving single dose of 20 milligram on day 3, and some people advocate 10 milligram OD for 10 days from day 2 to day 11. The results are different. Metformin again was a drug of choice earlier, but nowadays the use of metformin is very meticulous. We have to be very cautious in using metformin because it is not helping in that way, the way we used to think. Uh, explained us regarding the metformin. We can start from 500 and we can reach up to 1.5 to 2 grams as and when there are of IVF. Again, the metformin, if at all, it is given during the IVF treatment. How long it should be continued? It can be continued till 12 weeks of pregnancy, and after 12 weeks, if the GTT is deranged, then you continue the metformin with the help of physician and gynecologist under treatment. LOD, again, he has mentioned regarding LOD in PCOS, which is not very favorite of Jatin, but we are doing it as a, again, second line of treatment for those patients who are not affording for the gonadotrophins as a second line of treatment. Again, regarding LOD, it should be used with caution and with safe hands. Only whatever he has mentioned, the rule of 4 should be there. That should be strictly followed. Avoid drilling near the and cooling of the after the procedure is a must. Gonadotrophins, again, here has very clearly mentioned the gonadotrophins, they should be used either HP and recombinant gonadotrophins, they should be used. Antagonist. I will speak some lines on antagonists because antagonists in PCOS is a blessings, because earlier we used to face lot many OHSS in absence of antagonists. These antagonists have helped us in IUI and IVF. You have to calculate the doses as per the formula given by Jatin. We do IUI with antagonist cycles as well as with in IVF. We are using almost all the patient, even non-PCOS patient with high responders with high MH, we are using antagonist protocols. So we are not taking any chance of hyperstimulation in other patients also. In IUI and IVF outcome in PCOS, again, in PCOS patient, miscarriage rate is very high, as you know. So we have to supplement them with the progestins and the luteal phase support. Freeze-all and prevent OHSS is very important. Again, antagonist has played a very good role in this. All the PCOS patients should undergo freeze-all. They should be treated with antagonist protocol and with the agonist trigger, and freeze-all should be done to prevent OHSS. In summary, lifestyle modification, what we call as DEW, what we advise to the PCOS patient, that is DEW, diet, exercise and weight is very important. Drugs, which already we have mentioned, letrozole, CC, metformin, surgical procedures like LOD also help, low COC in some patients very meticulously in unmarried and girls. Metformin, again, in selective patients, letrozole should be used in spite of clomiphene, and second line of treatment should be LOD or gonadotrophins. Third line of treatment again is IVF with antagonist protocol and freeze-all. That's all, my friends. This is what I wanted to share with you. I'm really thankful to Jatin also for giving us eye-opener things which we used to follow blindly. And thanks to all the panelists for participating. As a MAGE president, Maharashtra chapter of IAG, myself and Niranjan Chauhan as a secretary, thank to you and all the sponsors for participating in this webinar. Thank you very much.
Thank you, Dr. Prakash Patil, for giving your excellent review about the PCOS. And obviously, I would like Dr. Jatin Shah to add a few comment or his observation in this regard, sir. And what do you feel the use of natural micronized progesterone in PCOS? So that also would be your understanding on that in luteal phase support or probably in ART.
Yeah, of course. So like I told you while I was talking that although there is a local style, although there is dydrogesterone, but MVP is like running in our veins and running in our blood since last 25 years. So it's not an easy decision to switch over. I'm sure most clinics will continue to use MVP because it's time tested, extremely successful. And we like to give it, in all IUI cycles, all OI cycles, even IVF cycles. And most clinics would continue the MVP support until, the luteoplacental shift occurs, which is usually at 10.5 weeks. So MVP is, of course, there to stay. And especially in fresh cycles and even in frozen cycles where we don't know, how effective dydrogesterone is or what the doses are. Because in a frozen cycle, you don't have a functioning corpus luteum. So a lot of things need to be sorted out still. We need more RCTs. But until then, of course, MVP is here to stay. So in IUI, we normally recommend 100 TID or 200 BID vaginally. We don't like the oral route, obviously, that everyone knows. And in IVF, it's usually around 600 to 800 per day in divided doses. Sustained release also works beautifully. Gel works beautifully. Capsules work beautifully. So it's finally the clinician's choice. So, but Niranjan, I must say hats off again to you and Dr. Prakash, because it's really, it's amazing that on Sunday evening you have more than 800 people online, and it's really gratifying to know that. So thank you.
Yes, sir. Yes. Sir, I'm asking you these questions because some of this will be repeated because there are many viewers who have joined later in the middle of the lecture or in the later half of the lecture, and they are very eager to know. So probably we'll be having some mix of those question and answers also, and we will also return back to you in between. So thank you so much, and I would like to tell that in the beginning we had 800 users and number has been soaring in, and now we have Dr. Anu Chawla from UK. She has specially come here to India. You can assume that we are now in amidst the conference of ART and PCOS, and welcome Dr. Anu. It is so nice to see you from London. How is the weather? How is the weather?
You can't say is she jet lagged anymore.
Yeah, I'm feeling the jet lag. I just flew from London to India now. Thank you, Dr. Niranjan, Maharashtra chapter of IAG, all the organizing organizations, Sun Pharma, Science Integra, for having me here. So to make good use of the 5 minutes that you've given me, I will put things into points. So when the patient comes and she has a hyperandrogenic features, in the differential diagnosis, it's important to keep the whole list in mind, but the worst differential diagnosis of androgenic tumor. For that, what I do is I do the total testosterone, and if that is between 2 to 5 nanomoles per liter, it corresponds with the PCOS. And if it is more than 5 nanomoles per liter, then it's very important that we rule out the androgenic secreting tumor, androgen secreting tumor in this patient. Just to get into detail of this, if it is more than 5, usually the labs use the immunoassay, which gives a quicker result, but it is more sensitive for the men's range of testosterone. So if you have a high index of suspicion, then you can go for the mass spectrometry. The next point is, if you have an 8 Hertz or higher frequency of the TVS probe, then ultrasound is very good. If not, the next best thing to do to test, to diagnose PCOS is 2-hour OGTT. The next point is, unfortunately, it has been ignored in the 2018 consensus, but Richard Legro, who's the who's done the best work in PCOS, and also one of my colleagues during my MRCOG days, Nick Fenning. These two people have done research and clearly proven that the stromal abundance and the increased PSV in the scan is very predictive of OHSS. So basically, it is not a good idea to depend on the ovarian volume, but ovarian volume can ditch you, the number of follicles can ditch you, but stromal abundance will always tell the patient is having a PCOS. So this is also a good way to predict hyperstimulation. There is another way, which is mean stromal area divided by the mean ovarian volume. If this ratio is more than 0.3 according to 0.34 according to one paper, and 0.32 according to another paper, if this ratio is more than this, then it is 100% specific of the diagnosis of PCOS. The next point is the criteria of 10 cc volume of ovary. It misses the weaker phenotype of those women who still equally are at the risk of 4 things, which is hyperstimulation, implantation failure, miscarriage, and hyperinsulinemia. As the previous speakers have already pointed out, that till the 8 years after menarche, so that means around 22-23 years of women's age, we need to see all 3 criteria and not just 2 out of 3 to diagnose PCOS. Another point is that PCOS is not a cause, it is the result of chronic anovulation. Basically, the anovulation ends up in change of granulosa to theca cells, and that builds up the stromal volume. So if you see a lot of stromal abundance, that means this patient has a chronic anovulation, and chronic anovulation is the cause of PCOS. Now, the next important point is the direction of the graph of the weight loss is more important than the absolute value. So as we know that even 5% of weight loss will make her ovulate. Another important point is people usually very commonly use cyproterone acetate for younger girls, but already it has been emphasized that it really increases the risk for the VTE, venous thromboembolism, and the use of COC pills, especially with cyproterone acetate, should be very carefully done for VTE, and also it is important we use the proper contraception so that they don't get pregnant while they're taking this hormone. The next thing is here in UK, I have seen some units, including my own one of the previous units that I worked in. Instead of clomiphene, they use tamoxifen for the IVF protocol in the case of PCOS, because they do not, so this prevents the the disadvantage of having a thin endometrium, and all those things are bypassed. So we will do a result publication, but then it is very promising so far. The next point is, in the worst cases of PCOS, it is better to start the drug later in the time. Like for example, if you're doing the ovulation induction for IUI, it is better to start on day 5 and not on day 2 or 3, so that we don't end up getting multi-follicular stimulation. A very important point is that these people should not be left after they get pregnant. It is very important point to tell them that a chronic anovulation and a typically worst case of PCOS is at a higher risk of developing carcinoma endometrium in future. I recently had a patient, she came from India and she had a very hyperplastic fluffy endometrium when I did the hysteroscopy. And these patients should not be left alone even after they get pregnant. It is best to put a Mirena so that it prevents against the endometrial carcinoma. Very important thing in the beginning is to check the GAD-7, so the Generalized Anxiety Disorder Questionnaire 7, to rule out that they're not developing any psychological issues. If this patient has a uterine size which is smaller, then because this happens because of chronic anovulation, so the uterine size in some of these patients is smaller. So in those cases, it is good idea to give them HRT and then do the IVF cycle. So just a few points. I think my 5 minutes are already over.
Thank you so much,
Thank you.
Dr. Anu. And nicely you have explained what are the causes of PCOS and how they occur. And it's really nice to hear from you. We have got some few questions. We'll get back to you soon. Thank you so much for being there with us.
Thank you.
And Dr. Prakash Patil, thank you. You are the chairperson of MAG, and because of your guidance and encouragement, we are doing this program. And really, we are very happy that we could get last year and this year Kamran Nezat and other international speakers. We had Dr. Lee from Singapore, then we had Dr. Chao from Korea, and obviously we had other international speakers also. Sergio, who had come from Spain, Israel, and we had Antonio from Italy, and today we have Dr. Anu Chawla from UK. So we have got that international flavor with MAG, and obviously Jatin Shah is the biggest personality with us today. He is a very down-to-earth person, and I remember when we had met the last time, I think the last conference most of us attended was in Hyderabad, courtesy Dr. Shanta Kumari Madam, and it was an annual ESHRE conference, and we flew down and all of us were there for 2 days, because I still remember after that there has been a lockdown period, and then India has been in a very bad situation presently also. So I remember those days and on those memories, and we really had a very good interaction from academic point of view. And I remember Jatin Shah is a very good singer, and Anuji, you also sang a nice Punjabi song. So we will get back to you apart from that academics, and we have got 2 more esteemed speakers. So Dr. Kusha, now I request you to please come on and unmute your mic. We have been hearing about you. You're a professor, and you also have a lot of experience of PCOS. So please share your experience of. Thank you so much.
Can you hear me, Niranjan?
Yes, sir. Yes, sir. We can.
Okay. Thank you. Good evening to everybody, and thank you, Niranjan, and thank you, IG, for including me, and thank you, Sun Spectra, for sponsoring this. Now, I've been hearing this, and almost all topics of PCOS has been completed. But to summarize, maybe I can say that PCOS is really a disease, a medical disease, not really only a reproductive disease. And it starts from menarche and goes up to menopause and even beyond that. So we can typically divide it into three phases, you can say. One is the adolescent, which has been very well touched by Dr. Ragini Agrawal regarding the obesity and basically the hirsutism. And in the mid-period, reproductive age, infertility has been spoken very well by Jatin Shah, which I've met him in many occasions and many international and national conferences. And of course, the other part of PCOS in the reproductive age group is the abnormal uterine bleeding. That is a very important part of PCOS, which Mirena and things like that will come in. And in the later half, as we know, the metabolic X, as we call the hypertension, the hyperlipidemia, triglyceride, cardiac events, and things like that increased. And the other one would be cancer, in endometrial cancer, which is also increased. And there are reports also with superovulation, we can have ovarian epithelial. So it's basically a whole spectrum of disorder. And if I may say that the major part that we should be managing the adolescent PCOS, apart from the oral pill and the lifestyle modification and the different types of metformin and things like that in obesity, counseling is very important, because 2 or 3 very special issues come in when the patients are brought in by their mothers. And one of them is infertility later on, because somehow and the other concern is PCOS is a cyst. They cannot differentiate between an ovarian cyst and a polycystic ovary. So that is one thing, that counseling is very important. Lifestyle modification is very important. As far as infertility is concerned, of course, the infertility and the IVF portion has been touched upon. Dr. Patil has touched a little bit on the laparoscopic ovarian drilling. I, being a laparoscopic surgeon, we do a few. It has decreased definitely. It's not like what it was before. But still, as has been mentioned already, that in ASRM and the ESHRE guidelines, it's still mentioned. So there is some scope of doing that, provided the patients are selected properly. Like there should be PCOS, there should be stromal volume, and LH should be high, and the technique should be right. For example, the rule of 40, which has been set, the 40 watts, 4 seconds, 4 punctures, 4 millimeter depths. And in both the ovaries, though there are some reports saying that unilateral ovarian drilling has also been tried by some. And what is important is to keep some fluid in the pouch of Douglas so that you can dip the ovary immediately after this. But of course, there has been reports of infection, ovarian adhesions, peri-ovarian adhesions, and things like that. And also studies have shown decreased AMH and that sort of thing. But LH and androgens have been shown to reduce after ovarian drilling. And as has already been mentioned, in 6 months duration after the LOD, almost the comparative between the gonadotropin and the laparoscopic ovarian drilling. So that portion I wanted to mention. And also we should always remember that after the reproductive phase is over, she should be kept, she should be counseled again so that it's not all over. And as we have already mentioned, the heart hypertension and things like that, and any bleeding around the age of menopause should be investigated. Thank you, Niranjan. Thank you.
Yeah. I think you have covered very nicely. And I usually get patients who are quite young. I got one MBBS student also I would like to share, and she was having 3 months amenorrhea, and she had no issues of basically any menstrual irregularities. But this girl was in 3rd MBBS, and she just landed up. She has already done one posting with me, and they usually come, all these girls, or they are in reproductive age, those who are just married, they come with those ultrasound report which says of PCOS and, query. And I think 30-40% of them come with those reports, and they are really, really anxious. So when we get their hormones done, and as Jayam madam had said, that out of 3, not all 3 have to be there, but only 2. So, and she had that, acne, and she had also, to certain extent, those hirsutism like. So I immediately, I also evaluated her, I counseled her. I think counseling is very important, and they are slightly on obese. So obviously the lifestyle modification, the dieting, a little bit of exercise, the walking, and I put her on cyproterone acetate also for a period of about 4 months, and then we again reviewed her, and that actually helped her acne, and that helped her reduce her weight. So I think it's very important that all these points have to be noted also. Dr. Jayam Kannan, you can just add furthermore in your 5 minutes.
Yeah, walking through these last 4 decades of seeing girls. Before transvaginal ultrasound, we were not looking at polycystic ovarian morphology. In 1980s, when we were in the beginning of our practice, we never had this entity as a big one. By 1990, it started being a big thing. And with the advent of we being the first batch of people to go for endoscopy training with Prashant Mankeshkar, we were very eager to do laparoscopic ovarian drilling. I have done 6 to 8 cases per day before 2000. Then slowly came into this ART procedures with which we restricted this ovarian drilling without knowing that we are compromising the ovarian reserve. 2010 is a time when AMH started coming up so much that we looked at the AMH and we found that our laparoscopic ovarian drilling is really dangerous sometimes in a polycystic ovary where the AMH level is not high. For Jatin and Prakash, I would still like to say, if I have a woman who is less than 30 years, married less than 3 to 4 years and she is not responding to the hormones and her AMH is about 10, laparoscopic ovarian drilling still gives us a success within 6 months if we allow her for normal, natural conception. This is quite documented, and with my experience with the 3 decades of ART and with 4.5 decades of gynecology, this is still my stand with all my academic outputs. And this ovary, what Anu Chawla said, the hilum, the medullary corpus medullary ratio, the thick hilum, if you see, if the tissue is quite high, definitely we can know well that this particular patient is going to respond either no, or she is going to be a hyper responder, which is going to be again decided by the AMH level. AMH of 3 to 4 with a necklace pattern of polycystic ovary with a big hilum is not going to respond with the OHS. But at the same time, if she's going to show a AMH of 9 plus, critically 12, yes, very sure, even with Jatin's 112 units of highly purified HMS, we are going to get hyperstimulation. Now we are all going in for OHS free clinic, in which this factor of AMH, which is now almost coming into as a marker for polycystic ovary, also lot of papers are coming in, and that should give us an idea that yes, AMH is not only for having your pregnancy rates and thinking of your endometriosis cases where AMH gives you the amount of endometriosis eating the ovary. It also goes in for a marker for PCOS, more so with the PCOS after the age of 20 years. Of late, we don't have too many papers on AMH in adolescents, whereas we have the papers on AMH in the reproductive life. That is what I think I should add up to all your beautiful outputs which you have given for this august audience. Thank you.
Thank you, Dr. Jayam. Dr. Jatin sir, there is a question for you from Dr. Milind Kolvalkar. He's asking, will not starting stimulation later cause negative estrogen effects of CC on the endometrium and mucus, hereby reducing pregnancy?
Not really in PCOS patients who are anovulatory, because even if you start day 4, day 5, day 6, as Anu pointed out, you will have a slightly lower incidence of multiple pregnancies, but the time to ovulation is going to be the same. So she's not going to ovulate on day 14 if you start on day 5. Because if she has a 2-month, 3-month oligomenorrhea, amenorrhea, she's going to take 14, 15, 16 days anyway. So I don't think that will make much of a difference. But it's a good question.
Thank you. Dr. Agini, there is a question. You are the authority of adolescent PCOS, and you have got a lot of experience about acne, hirsutism, and about obesity. Those patients are coming to you with young girls. First of all, I would like to advise, I would like your opinion and to advise these young girls who are there, who are in 15, 16, in their school days, in their college young days. And most of them are nowadays stuck up with their phones, with Instagram, with Snapchat, with all those social media, hardly going out, even to play as a schoolgirl in a playground. Obviously now in Corona times, we are all barred and not going. But what would you advise to these young girls now? They are just sitting at home. Probably they are having a teleconferencing or a video conferencing with you. There's one question also from Dr. Veena Goyal. She has written that there's one 16-year-old girl and she has got secondary amenorrhea for 2 years, and how you will go about it. And 2 years back, she had withdrawal bleeding. So I can divide this question into 2 parts. One is the advice to these ladies, girls who are sitting at home in this Corona time. Second is for a 16-year-old girl with 2 years of secondary amenorrhea, and what precautions, how will you do, when they should come to you for further treatment.
Okay, Niranjan, it's a good question how to advise these young girls. The young girls advise when they come to you. never send those patients for any counseling to someone else because they have a faith in you. I do my diet counseling to them. I do my exercise counseling to my patient. I don't send to any dietitian or any physiotherapist or any coach. And if I say, do this exercise, I know my young girls are not going to accommodate that. For them, the best exercise to make them the Bollywood heroine. Tell them, learn the dance, put a video, have a 1 hour dance, and believe me, they are happy, they are smiling, and they do it. And the diet you have to prescribe them from by yourself. I have my own type of diet education to them. I write it. I don't give a type pamphlet to them. Take this diet. This is this much of carbohydrate you have to have. This much of the protein. No. I tell them what to take, when to take the water. You know, I have to gain a confidence with them, because it is not only that. Because as I told you initially, a big chunk of the adolescent PCO comes to me. They come for the cosmetic concern to my other side of the clinic. And their cosmetic concern cannot be properly, we can address unless I stabilize their PCO, which is very, very difficult to stabilize. I'm not giving to them any hormone, and I'm not happy to label them as a PCO, although I know they will come afterwards as a PCO. Even then, I don't want to stamp this level of the PCO in the early stage of 12 years, 13 years, 14 years girl. I will keep silent, tell them do this thing. We will see, maybe when you grow up, you will not a PCO. So diet, exercise in a good way, in a different way, always you have to advise. The girls, when they are sitting at home, you know, there's lots of video on their home walking videos, home exercise video, and especially the dance and a group dance. Today, a chunk of my patients, they have in between, they have developed a type of dance with this Zoom only, you know. So Zoom education has become a very big thing in the education and the counseling. So we have to come out of box thinking. And second question of the amenorrhea, what you think? They asked me, the 2 years of the secondary amenorrhea, we cannot put only on the PCO. We have to go and see all other reason of the secondary amenorrhea and evaluate patient properly for all the causes of the secondary amenorrhea, starting from the complete evaluation of the hormones, ultrasound, and everything. Even if a girl coming to me, say one episode of the menses, then goes into the amenorrhea, I will like to see even the chromosome also for that patient. So even I just remember one girl who has came to me for the 3 years of the amenorrhea. She had 2 or 3 cycles of the amenorrhea, and that girl come out to be tuberculosis positive. So there's a long
causes
for the secondary amenorrhea. We can't say that this girl is having a only PCO and having a men's amenorrhea.
Absolutely. I think we have covered most of the points, and there's one question about this newer insulin sensitizers, and we have myoinositol. So what do you feel? Is it helpful?
I'm very happy. If you ask me, I'm very happy, especially as it is a nutritional supplement to give to your youngers. It is very nice. If you don't write any prescription and just say them go and do the exercise and this thing, they will never fully take your prescription. If you write something along with that, they're very happy. So my adolescent patient, I'm very happy with this inositol. Yes, not only this is a placebo, they respond to it also. I respect this drug.
Even in the IVF point of view, we are just doing a trial, so I don't have the data yet. But we are using a combination of myoinositol, pea protein, folic acid, and some other supplements, ready preparation for 2 months pre-IVF. Because we've given about 40-50 patients. We still don't know the data, but on grossly it appears that there is an improvement in oocyte quality. So, but we don't have enough RCTs yet, so we have to wait.
Well, thank you so much, all of you. I think we have covered most of the points. At the end, I would like to ask you one take-home message a one-liner for all your patients and the doctors who are viewing this program. What is your take on PCOS and a take-home message from starting from Dr. Jatin Shah?
Oh, so for fertility, of course, 2 cycles maybe of letrozole, 2 cycles clomiphene or with metformin or gonadotropins. If all fails, then a 3-musketeer approach, antagonist protocol, 150 to 200 of FSH or HMG, time will tell, freeze all policy and 0 HSS clinic. So I think that's the way to go and a very successful way to go for PCOS.
Yes. Dr. Prakash Patil?
Yes. As far as PCOS are concerned, the ways our speaker said, catch them earlier, tell them that the window of obstetric career is short and they should be taken, they should take the treatment as early as possible and they should go systematically with drugs and don't directly go for LOD or gonadotropins, give them natural chance. And the most important OHSS, what we have seen, which is deadly complication, should not be there in PCOS.
Thank you so much, Dr. Kusha.
Yeah, I would summarize by saying that PCOS is still an enigma after so many decades of knowing the first coinage of the term Stein-Leventhal syndrome. We still don't know what is causing it. And mostly things are unknown than what we know already. So we should watch the space. But as a whole, we should be counseling the patients when they come at different stages of their lives with their individual symptoms. And we have to monitor them. That is very important. And maybe one day with genetic breakthrough, we might be able to know the cause of PCOS, maybe multifactorial, multigenetic, epigenetics will be involved because a lot of studies are going on epigenetics of PCOS. So it's not only the genetics, the constitution of the woman, it's not only hereditary, it's the environmental influence on the genetic component which can actually manifest it as PCO. And differentiate between PCOS and PCO, that is one of the very important things that we always keep on confusing. Thank you.
Thank you, Dr. Kusha. I would also ask you one question because there are 3-4 questions which have just come in now. I will be asking to Jatin and Anu also one each question. Dr. Kusha, what is the role of metformin in thin and lean PCOS? This is a question from Dr. Suba.
I really don't use metformin for lean and thin PCOS, but yes, there are studies which have used it, and maybe Jatin will be able to say further.
I gave very clear indications where all it should be used. So the thin lean PCO is not one of them.
Okay, fine.
Correct.
Jatin,
Correct.
Thank you for coming in here. There's one big question from Dr. Neha Sardar. I'm just trying to read it. Lean PCO patient with multiple follicles not responding to CC Letros, planned for gonadotropins. Previous cycle was sequential step-up regime, but went into OHSS, was started with 75 international FSH with gradual increment 37.5, led to cycle cancellation. Now LH is 23. Dr. Jatin, please opine. This is Dr. Neha Sardar.
Yeah, so as I told you earlier, the best would be for this patient maybe to start with 37.5 or 50 max. Another very important point is to counsel her beforehand in the second cycle. Every time we can't keep cancelling. If you are prone to hyperstimulation, you please be prepared that I'll convert you to an IVF cycle where we can just freeze all the embryos. The trick is not to keep stepping up too fast. In such a patient, you should wait for the actual 14 days as the original recommendation is. So if you start with 37.5 or 50, wait for 14 days, then make the first increment. And the increment should be just by half. So if you started with 50, you just increment 25. So that's how it has to go. Even if it takes 30 to 40 days follicular phase, there's no problem. 40 to 50% of the time you will escape with monofollicular development. But for the others, you might require a last minute conversion to IVF. So you have to counsel the patient before you start. Whenever you have a thin lean PCOS, best is to tell them, okay, we'll have only 2 options. Either I cancel because OHSS can be life threatening, or I take you to so-and-so center which is nearby. We just do an egg pickup with an agonist trigger and give you a maybe a 3 times higher chance of pregnancy. So I think that should be the way to approach this patient.
Thank you, Dr. Jatin. So nicely explained. Dr. Anu, this lady is from she's Dr. Toon Win O from Myanmar, and she has said lifestyle modification alone may be effective for pregnancy in PCOS? Dr. Anu.
Your voice is breaking. You said lifestyle modification alone.
Yeah, she is asking that only lifestyle modification alone, will it be effective for pregnancy in a PCOS patient? What is your take on that?
Yeah, so the answer is yes, and that will happen in the majority of the patient. As I said, that even 5% of weight loss is going to create ovulation in most of the women. And we don't need to really tell them to go home and lose 10 kgs of weight. Losing weight is the hardest of the jobs, and it's not easy. So we cannot just be unrealistic. And even 5% of the loss of the weight, for example, a 100 kg woman, if she loses 5%, that means 5 kgs, will start ovulating. So the answer is yes. And that is the first line therapy actually. So yes.
Thank you. Dr. Prakash Patil sir, this is Dr. Sunita. Can we start an adolescent PCO on myo-inositol?
Just as what Dr. Ragini said, it is just a additive nutritionist. But as far as myo-inositol is concerned, if it is given during the IVF cycle or 2 months before the IVF cycle, then it is helping. Otherwise, in adolescent as such, I don't think that it will help. I don't have any experience about that. We don't prescribe myo-inositol.
Okay. So there are different school of thoughts, but I'm sure we have got a lot of variety of opinions coming from the IVF consultant, from an endoscopic surgeon, from an authority of adolescents, a committee chair, and a madam who does.
Niranjan, regarding that previous question, I just wanted to highlight something.
Please.
As referred, I just wanted to highlight that we had a patient similarly like this, PCOS patient, who had infertility 5 years. We have done IVF, we have frozen her embryos. Meanwhile, 2-3 months, she had undergone this keto diet and she's reduced from 65 to 50. She conceived naturally. She after weight loss. Means the lifestyle modification is very important. 5 years long-standing infertility with PCOS, conceived naturally, her embryos are still frozen with us.
Yes. Now, suddenly what has happened is that the whole, since the discussion has started, I got many live questions. So that's why I had to literally stop in between the take-home messages. And really, there is one comment from Dr. Milind Kovalkar, Goa. He has said, Dr. Niranjan brings life to moderation. So I thought I should put this.
Certainly, Niranjan, I fully agree with him. Whatever you are arranging all these webinars, you are so instrumental and so active that everybody wants to see you as a moderator. You bring live in all the webinars. You make all the panel moving and laughing all the time. Thank you very much for that.
Thank you.
Totally agree. Totally, yes.
Thank you. Thank you so much.
You revolutionized the art of moderation.
Yeah.
Oh, thank you so much.
It's really a wonderful panel, Niranjan, and thank you for giving us all the opportunity.
So we will take a last question, then we will end here because there are 2 or 3 questions, but it's a very important. How many cycles of OC pills should be given to a young, say 20 years old girl who does not bleed without withdrawal? This is Dr. Poonam Sinha. How many cycles of OC pills should we be given to a young girl of 20 years old who does not bleed without withdrawal? I mean, she has to be given how many cycles? Yes, madam.
Yes. So 20 years old girl is definitely not coming for infertility. She's just coming for amenorrhea, basically. So now the very important point that I want to highlight, taking advantage of this question, is that I really want to emphasize that it is very important that we make this girl bleed at least 9 times in 12 months. And that is what is not being practiced. I'm sorry, but yes. So that is what I've noticed. That is not being practiced. But this is basically to prevent that hyperplastic endometrium which will form, and she will have a struggle with the implantation if she goes for fertility in future. And then in future, she will have a higher risk of carcinoma. So it is very important that we make these girls bleed at least 9 times in 12 months.
Yes.
So the cycles of OC pills is number of cycles is not important. You can give it for 10 years also if you want. If she's a resistant PCOS who's amenorrheic. So the main thing is it is prudent to make them bleed 9 times in 12 months at least for many reasons.
Okay. Dr. Milind Kovalkar has said from Goa, hi Anu, welcome back and nice lecture. You also had a good presentation. And
hi Milind.
It was really, thank you so much. And
he's doing
thank you
very
all
well.
of you.
His practice in Goa is roaring.
Okay.
So congratulations Milind for your practice.
So I think we are nearing the end of the program. Jatin, would you like to end with the song of your favorite song?
Anu, ladies first.
Anu, just 2 lines, and then Jatin, and obviously all of us can join chorus.
Today I would request you to excuse me, and I would request Dr. Jatin to go ahead. Sorry.
Okay, thank you.
So all good things have to come to an end, and thank you Niranjan, thank you Prakash, thank you all esteemed panelists, and of course since we are coming to the end, I can't think of a more appropriate song than चलते चलते मेरे ये याद रखना कभी अलविदा ना कहना कभी अलविदा ना कहना बीच राह में दिलबर बिछड़ जाए कहीं हम मगर और सुनी सी लगे तुम्हें जीवन की ये डगर हम लौट आएंगे तुम यूं ही भुलाते रहना
अरे वाह
कभी अलविदा ना कहना कभी अलविदा ना कहना
Thank you so much, Dr. Jatin and Dr. Jayam, Dr. Agini, Kusha, Dr. Prakash Patil, Anuji, you come from UK. We will be ending the program now. I request the slides to be put on. Please share the screen. It is a wonderful way of ending this program. When you look at a person, any person, remember that everyone has a story. Everyone has gone through something that has changed them. Next. Can we have the next slide?
Oops.
There is one more slide. Can I have one more slide? Yeah, thank you. Thank you so much. What is the definition of flawless or flawsome? Basically, the definition of flawsome is it's an adjective, an individual who embraces their flaws and knows they are awesome regardless. So all of you are awesome. And हम सभी में कई सारी त्रुटियां हैं जो हमारे पास है, वो हर किसी के पास नहीं. दृश्य नहीं, दृष्टिकोण बदलना आवश्यक है. हम सभी का दिन उत्सव, ऊर्जा, आनंद से परिपूर्ण हो. और इसी के साथ ये मैं समाप्त करना चाहता हूँ. फिर मिलेंगे आप लोगों के साथ TOG वेबिनार में इसी समय और यही प्लेटफॉर्म पर. तब तक अलविदा and have a nice time.
Bye delegates.
Bye.
They are back to all the delegates also.
फिर मिलेंगे ऐसा बोलो निरंजन. फिर मिलेंगे.
Bye bye.
Thank you very much. Niranjan, Anu, Kusha, everybody, Kannan, everybody. Thank you very much for joining.
Thank you, one and all.
Bye bye.
Thank
Bye.
you.
Bye.
Thank you, doctors. Thank you so much.
Thank you.
Thank you, doctors. Thank you so much for your time. Thank you so much. See you again.
Bye.
So it was wonderful to have you all. Anuji, Meenal, Jayam.
Thank you so much, doctors.
That was very, very too much of fun with a lot of learning, and thank you for actually, all of you are so seniors and I've listened to your all lectures and learned, and I'm so proud of having a very good teaching in India. And thanks to all of you, especially thanks to Dr. Niranjan today for having me, and Dr. Jatin also. Congratulations for a great talk today.
Thank you so much. Thank you.
Thank you, doctors. Thank you. Bye. See you.